Welcome to 4526 Class 2 or Week 2, Part 2. So in this part of the lecture, we're going to talk about respiratory distress versus failure, endotracheal intubation, and mechanical ventilation. There will also be lecture notes posted online to help you with this material. So first, let's talk about respiratory distress and respiratory failure. Oftentimes we use these terms interchangeably, however, they are not. Respiratory distress is increased work of breathing in the presence of normal state and oxygenation abilities. So it's characterized by increased respiratory rate and an increased respiratory effort in an attempt for your body to maintain homeostasis. Respiratory failure happens when homeostasis can no longer be maintained. So typically you would have normal oxygenation levels in respiratory distress. When the respiratory system can no longer fulfill the gas exchange needs of the patient, so there's inadequate oxygen or inadequate exchange of oxygen and carbon dioxide, that's when respiratory failure happens. So usually respiratory failure is defined by abnormalities in the partial pressure of oxygen and the partial pressure of carbon dioxide. And you see these values when you do a blood gas. So just remembering the gas exchange. So again, the gas exchange is the exchange in the alveoli between oxygen and carbon dioxide, and in respiratory failure, this ability to exchange, or the gas exchange, is not taking place properly because the patient is in acute respiratory failure. Traditionally, a patient can have hypoxic respiratory failure when their PO2 is less than 60, or hypercapnic respiratory failure when their PCO2 is greater than 50. And sometimes there's a combination of both. So as you can see here, I've given you the differences in the abnormalities between PO2 and PaCO2. And at PO2 less than 60, you're looking at hypoxemia, insufficient oxygen delivery to the blood. Remember, hypoxia is only happening within the lungs, within gas exchange. Hypoxemia is looking in the greater body system. Or a PCO2 greater than 50, which is showing inadequate CO2 removal, and you get hypercapnia. Even though respiratory failure is determined by the PaO2 and the PaCO2, the major threat is the inability of the lungs to meet the oxygen demands of the tissues and vital organs. This may occur as a result of inadequate tissue oxygen delivery or because the tissues are unable to use the oxygen delivered to them. Typically, what you will see is a change in blood gases and a change in pulse oximetry, so you need to continue to monitor both of those. A change in mental status is frequently the initial indication of respiratory failure. Tachycardia and mild hypertension can also be early signs of respiratory failure, as well as cyanosis. But cyanosis is more of an unreliable indicator in the early stages. Typically, we see that as a late sign of respiratory failure, and then, of course, an increase in respiratory rate. So let's move on to endotracheal intubation. So endotracheal, or ET intubation, involves the placement of a tube into the trachea via the mouth or nose, which goes past the larynx. So what are the indications? The indications include someone who is at a high risk for aspiration. So I would think of those individuals as the stroke patients who have lost their swallowing reflex or their cough reflex. It allows for suctioning of secretions, so someone who is ineffective in clearing their secretions. It provides a route for mechanical ventilation and oxygenation for those individuals in respiratory failure. We spoke earlier about upper airway obstruction, so secondary to burns, tumor, or bleeding, some type of trauma, and then individuals who are apneic. So let's look at the endotracheal tube. So here you will have the picture of the endotracheal tube. This is what comes out at the lip level where you would connect in the oxygen source, so the mechanical ventilator or your ambu bag. This is the cuff inflation line, and you would inflate it here, and you have a balloon here that gives you an indication if the tube is inflated, or sorry, if the cuff is inflated or not inflated. So here is an example of the tube in the trachea with the cuff deflated. The only times that the cuff is deflated is when you're inserting, removing, or repositioning. And that would not be done by the RN, but you would be assisting in that. And you need the cuff inflated at all times to maintain the positioning of the tube. But this is something, recognizing whether the cuff is inflated or not inflated is something that you will be monitoring for. So why would you choose oral, nasal, or tracheotomy? So the indications for oral ET intubation or oral tracheal intubation, it's the procedure of choice for most emergencies because the airway can be secured rapidly. A large diameter tube can be used, thus reducing the work of breathing, and it makes it easier for suctioning. And it also makes it easier for a bronchoscopy to be done at a later time if needed. Nasal tracheal intubation is really only done when the head and neck manipulation is risky. So if there's a concern about a cervical spine issue. And then a tracheotomy is a surgical procedure that is performed when the need for an artificial airway is expected to be long-term. And also maybe in those situations where there's significant trauma to the facial area, so oral and nasal, and you just can't intubate in those areas. So let's go through the ET intubation procedure. So the equipment that is needed is a self-inflating bag valve mask, so your ambu bag, which is attached to oxygen, suctioning equipment, and intravenous access. So those are the three things that you would need to make sure that are at the bedside and that RT is going to be present during the intubation. Pre-medication depends on the patient's level of consciousness, whether they're awake or they're obtunded, and the nature of the procedure. Is it something that's emergent or non-emergent? So you're going to tell the patient and the caregiver, if they're awake, the reason for the intubation, the steps that will occur in the procedure, and the patient's role in the procedure, which is not really a role at all, just to remain calm. It's also important to explain that while intubated, the patient will not be able to speak, but that you will provide other means of communication. And then the bag valve mask, again, it's connected to oxygen, and you want to ensure that you've cranked the oxygen up to as high as it can go to make sure that you are giving a very high, almost 100% concentration of oxygen. And that is really it for intubation. It usually will be done by a physician, and sometimes NPs have been trained to do that as well as an RT. So before the intubation, the RT, the NP, or the MD is going to pre-oxygenate using the ambu bag with 100% oxygen for 3 to 5 minutes. Then you're going to limit each intubation attempt to 30 seconds. So you're going to pre-oxygenate the patient to make sure they're full of a good 100% oxygen. Then you're going to take the ambu bag off. You're going to try the intubation. If it's not successful in 30 seconds, you're going to put the ambu bag back on, and you're going to ventilate again. And you're going to continue until you have a successful intubation. For oral intubation, you're going to place the patient supine with the head extended and the neck flexed. So this is called the sniffing position. And this position allows for visualization of the vocal cords by aligning the axis of the mouth, pharynx, and trachea. For nasal intubation, it may be necessary to spray the nasal passages with a local anesthetic and a vasoconstrictor. So following intubation, the RT, MP, and MD. So typically the RT will be the one that's going to inflate the cuff and confirm placement of the ET tube while manually ventilating the patient with 100% oxygen. An end-tidal CO2 detector measures the exhaled CO2 from the lungs, and it gives you a good indication that the tube is in the right place. You place this end-tidal CO2 between the bag valve mask and the ET tube, and you observe for a color change or a number. And also the other way to check to make sure it's in the proper place is to auscultate the lung bases and the apex of the lungs for bilateral breath sounds. If there's no CO2 detected on the end-tidal CO2 detector, then the tube is in the esophagus and needs to be reinserted. These are some of the complications of intubation. So you may have spasm in the bronchus or the larynx. The patient may aspirate during the procedure because they could start coughing, or maybe they've been vomiting. Tooth damage, just if it's a traumatic intubation, you may have tooth damage. Again, injury to the lips, mouth, pharynx, and vocal cords because it could have been a traumatic intubation. Hypoxemia during intubation because, again, you are going to hyperventilate the patient with oxygen for the 3 to 5 minutes, but the patient could still lose a lot of oxygen and gas exchange during that time. So the organs could become hypoxic, the air exchange could lead to hypoxemia. So remember, hypoxemia is at the tissue level, hypoxia is at the gas exchange in the alveoli. And then tracheal stenosis, erosion, and necrosis. This happens later on if the tube has been left in for an extended point of time. And we're going to talk about that. So what is the initial nursing management? You're going to help confirm the placement. And every time you come on shift, you will confirm the placement. You will listen for bilateral breath sounds. The end-tidal CO2 is a disposable detector that may be left on, or maybe something that you will use in the ICU setting. You'll look for bilateral chest movement. Chest x-ray will be done daily to ensure that the tube is in the right place. And you will be responsible for measuring, marking, and documenting the distance from the edge of the lip to the end of the tube and periodically monitoring this mark. So it's very important to ensure that you have the correct tube placement and with turning and repositioning the patient that the tube does not get dislodged. So measurement again is you are measuring and marking and documenting this distance from the edge of the lips to the end of the tube to ensure that this mark is not changing from shift to shift or after repositioning the patient. So let's look at some nursing management after the patient has been intubated, and something that you will do on a shift by shift basis, or every shift you will do this, and you will do this more than probably once or twice a shift to ensure that you are managing the airway properly. So we're going to go through these 7 different areas of management. So maintaining correct tube placement. So the patient with an ET tube should be continuously monitored to ensure the tube remains in the correct place. Proper tube placement is maintained by confirming that the exit mark on the tube remains constant while at rest, during patient care, repositioning, and patient transport. The nurse also observes for symmetrical chest wall movement and auscultates to confirm bilateral breath sounds. It is an emergency if the ET tube is not positioned properly. And so when that happens, we'll go on to the next slide. If you find that you have an incorrect tube placement, you need to ensure that you stay with the patient, you maintain the airway, support ventilation, and secure the appropriate assistance to immediately reposition the tube. It may also be necessary to ventilate the patient with a bag valve mask and 100% oxygen. If there is a dislodged tube and it's not repositioned, what's happening is there's minimal or no oxygen is being delivered to the lungs, or the entire tidal volume is delivered to one lung. So if it's got shifted and it's only going down into one bronchus, the other lung is not getting ventilated at all. And so this places the patient at risk for a pneumothorax because there's a high pressure of oxygen going into one lung and not the other, and the lung could collapse. And we'll talk about pneumothorax later. Number 2 is maintaining proper cuff inflation. And so the cuff as you remember from the previous picture, is an inflatable, pliable sleeve, and it encircles the outer wall of the ET tube, and it stabilizes and seals the ET tube within the trachea and prevents escape of the ventilating gases. So the cuff can cause damage to the tracheal mucosa, if it's moving around. So that's really important. And so to avoid damage, the cuff is inflated with air, and the pressure in the cuff is measured and monitored. And this is done by the RT. And so it will need to be measured and recorded after intubation and on a routine basis, usually about every 8 hours, to ensure that there's no leak going on. And so if you can't, sometimes you get a leak in the tube or a hole in the tube, in the cuff. Sometimes you get a hole in the cuff. And so if you can't maintain an adequate cuff pressure, what happens is that the cuff could be leaking or there could be tracheal dilation at the cuff site. And in these situations, the nurse should notify the physician or the RT to reposition or change the tube. These are examples or pictures of looking at a trachea that has damage. And so as you can see up here, you've got some erosion in the trachea from maybe a cuff that's been deflated and the ET tube is moving around. Again, this is all nice pink air right here, but this is tracheal damage, and here's tracheal erosion. So again, the importance of making sure that the cuff is inflated and in proper position so the tube cannot move around. Number 3 is monitoring oxygenation and ventilation. So remember that oxygenation is measured through your pulse oximeter or your SpO2 and your ABGs, which would be your saturation of arterial oxygen, so your SaO2. Clinical signs of hypoxemia or a change in mental status, anxiety, dusky skin, and dysrhythmias. Remember, ventilation is observed through your PaCO2. And so the best indicator of alveolar ventilation is in hyperventilation, you could have a decreased PaCO2, and hypoventilation is an increased PaCO2. Clinical signs of respiratory distress or poor ventilation is use of accessory muscles. Hypoventilation you could get with dusky skin. Hyperventilation you could get peripheral or numbness around the mouth and tingling. Now these are typically things that you would not see. The tingling and numbness, typically your patient will not be able to tell you that, because when they are intubated and ventilated, they are sedated. Maintaining tube patency. And so it's very important to ensure that you do suction your patient, but you do not suction your patient routinely. It used to be when I would suction my patient every 2 hours. It was a routine thing. And so this has changed to be something that you only suction the patient when they absolutely need it. And so indications for suctioning could include you visibly see secretions in the ET tube. There's a sudden onset of respiratory distress, so there may be an increase in the respiratory rate or sustained coughing by the patient. A sudden or gradual decrease in the PaO2 or the SpO2. Suspected aspiration of secretions, or you've auscultated and you've heard adventitious breath sounds over the trachea and or the bronchi. So suction techniques, there have always been 2 different types of techniques, an open suction technique and a closed suction technique. And so a closed suction technique is uses a suction catheter that's enclosed in a plastic sleeve connected directly to the ventilator circuit. And so with the closed circuit technique, oxygenation and ventilation are maintained during suctioning, and exposure to secretions is reduced. So typically, I'm sure that all ICUs are only using this type of suctioning now. You're not disconnecting the individual from the ventilator to put a suction catheter down, especially due to COVID situations. If for some reason you have to disconnect the individual from the ventilator and do an open suction technique, you're basically just putting the suction catheter down the ET tube when you disconnect. But this is typically the route that is the route that's happening now is this closed tracheosuctioning system. So when I used to suction, we would disconnect the patient. We would suction, you would ventilate the patient, you would suction down the tubing, and then you would reconnect the patient. But now it's an inline suctioning, and it's an attachment that's on the endotracheal tube, and there's no reason to disconnect. And so again, it limits the spread of secretions, and it also maintains the ventilation and oxygenation because you don't need to disconnect. So the importance of maintaining the tube patency. So again, possible complications associated with suctioning, hypoxemia. You could put the patient into bronchospasm. It does increase intracranial pressure. So people who have head injuries, you really limit the amount of suctioning that's happening because it will cause the patient to cough, which increases the intracranial pressure. You may get arrhythmias. You may get hypertension or hypotension. The amount of suctioning, if you're suctioning a lot, it's going to cause mucosal damage and bleeding. It is painful, and you could be introducing infection. So you really do need to decrease the amount of suctioning and only do it when it's warranted. So, how do you limit suctioning complications? You assess the patient before, during, and after suctioning. If the patient does not tolerate suctioning, you need to stop the procedure and manually hyperventilate the patient with 100% oxygen. If you're performing a closed system, you can actually hyperoxygenate the patient through the ventilator. You want to limit your suction pressures to under 120, and you want to avoid overly vigorous catheter insertion. It's got to be a very very gentle procedure. How do you manage thick secretions? Well, it's very important that the patient is adequately hydrated through typically intravenous fluids and supplemental humidification. We used to instill normal saline down the ET tube prior to suctioning, but that's no longer in practice. Number 5 is providing oral care and maintaining skin integrity. So oral care should include toothbrushing twice a day, along with the use of moistened mouth swabs and frequent oral pharyngeal suctioning with a Yonker to provide comfort and to prevent injury to the gums and plaque accumulation. The ET tubes should be repositioned and retaped every 24 hours as needed. And so it typically goes from one side of the mouth to the other side of the mouth to make sure that you don't have necrosis happening on the inner parts of the lips. And this is a 2 staff member procedure because one needs to hold the tube while the other one repositions and tapes. And while you're doing this, you monitor the patient for signs of respiratory distress throughout the procedure, just to ensure you haven't moved the tube out of correct position. Fostering comfort and communication is extremely important. You can imagine what it must feel like to be intubated. So intubated patients may experience anxiety because of the inability to communicate and not knowing what to expect. The physical discomfort associated with ET intubation and mechanical ventilation often necessitates that the patient is sedated and you're administering analgesics until the ET tube is no longer required. So typically you will have 2 IV drips going, one for sedation and one for analgesia. And then other complementary therapies could be relaxation techniques such as music therapy. These can complement drug therapy. What about complications of endotracheal intubation? Well, the first one is unplanned extubation. So this is removal of the ET tube from the trachea, and it can be a catastrophic event. It's usually due to either the patient has removed it themselves or accidental removal during movement or a procedure. Typically, the low pressure ventilator alarm will go on, and we'll talk a little bit about alarms in a little bit. You're going to have diminished or absent breath sounds. The patient will be in respiratory distress, and it could be related to gastric distension that's actually moved the tube. So how do you prevent unexplained extubation? Well, you ensure that there's good, secure attachment of the ET tube. You support the tube during repositioning and procedures. If needed, you may have to put soft wrist restraints on the patient. and provide the sedation and analgesia as ordered. What if it happens? Should an unexplained extubation occur, you stay with the patient, you call for help, you manually ventilate the patient with a bag mask valve and 100% oxygen, and you provide psychological support. Other complications could include aspiration, and so this is a potential hazard for the patient with an ET tube as the tube passes through the epiglottis, which splints it and keeps it in an open position. And so some ET tubes provide continuous suctioning of secretions above the cuff, which could be constantly suctioning anything that could be coming from the GI system. So why would aspiration happen? Improper cuff inflation, it could happen during patient positioning, or maybe there's actually been the development of a fistula or erosion because of improper cuff inflation. How do you prevent it? Well, you suction the oral cavity frequently, and very important that if the patient is receiving any type of GI feeds or NG feeds, that the head of the bed is raised to a minimum of 30 to 45 degrees unless it's contraindicated. So I encourage you to take a break, and then we'll move on and discuss mechanical ventilation. So now that we've intubated the patient, the next step is mechanical ventilation. So what is it? It's the process by which FiO2, so oxygen, either room air or greater, is moved into and out of the lungs by a machine. So why? What are the indications? Anything that impedes a person's ability to ventilate themselves. So someone who's apnea or apneic, or impending inability to breathe or protect the airway, acute respiratory failure, severe hypoxia, respiratory muscle fatigue. So such things as COVID-19, acute respiratory distress syndrome, an overwhelming pneumonia, an exacerbation of COPD, maybe a pulmonary embolus. Respiratory muscle fatigue, oftentimes individuals who are very weak, have had a stroke, have had some type of insult to muscles. They will need a ventilation. Maybe something's happened to the respiratory center in the brain. So a stroke, a trauma, or a head injury, or maybe a neuromuscular disturbance. So Guillain-Barré, multiple sclerosis, ALS are some examples. So there's two types of ventilation, either positive or negative. Negative ventilation we do not do anymore. It was the initial types of ventilation. So it involves the use of chambers that encase the body or chest, and it applies intermittent negative pressure. It used to be called the iron lung, and it was developed during the polio endemic, but it's not used now. Positive pressure is what is used now, and it's used primarily for acutely ill patients, and it pushes air into the lungs under positive pressure during inspiration. Expiration occurs passively as a normal expiration. So again, positive pressure is exerted during inspiration, and it increases the tidal volume, and there's different inspiratory cycles depending on the type of ventilation. So it could be adjusted for volume, so it delivers a preset amount of volume during each cycle. It could generate a certain amount of pressure, so there's a preset pressure that needs to be met each time air is delivered, or it could be based on time, so it generates flow for a preset amount of time. Let's go through the different modes of positive pressure ventilation. So the ventilator mode is based on the work of breathing that the patient ought to have in normal circumstances, or the amount that the patient can perform right now, and is determined by the patient's ventilatory status, the respiratory drive, and the ABGs. So you step back and take a look at what's happening with this patient. If they're 100% respiratory compromised, they're apneic, then they need 100% work of breathing done by the machine. If the patient is breathing on their own, but they need some type of an assistance, then the ventilator can be set to assist the patient. So as such, the ventilatory modes are controlled or assisted. So with controlled ventilatory support, the ventilator does all of the work of breathing. With assisted ventilatory support, the ventilator and the patient share the work of breathing. So in the controlled ventilation, the ventilator provides all of the patient's ventilation. The RT will set the rate, the volume, the time, and the pressure. In assisted control ventilation, it delivers a preset tidal volume at a preset frequency, and it assists the patient that when the patient initiates a spontaneous breath, the preset tidal volume is delivered. So the patient can breathe faster than the preset rate, but not slower. And so this mode allows the patient some control over ventilation while providing some assistance. So the next type of ventilatory setting is synchronized intermittent mandatory ventilation. So remember, as I said in assist control, that it is programmed that it is going to deliver every time the patient takes a breath, it's going to deliver a set amount of volume with a set amount of pressure at 12, say it's going to set at a certain rate. So 12, typically 12 ventilations an hour. And it's based on if the patient takes a breath, then it's going to deliver that much. Even if the patient drops below 12, it's going to automatically deliver those 12 breaths. Synchronized intermittent mandatory ventilation is a little bit different in that, yes, they do set a preset tidal volume or pressure, but it allows for spontaneous breathing in between with no work from the ventilator. And typically these are set lower than assist control, usually about 8 breaths per minute. And it is synchronized with the client's efforts. So yes, it will deliver 8 breaths a minute at a certain pressure and volume, but between the ventilator delivered breaths, the patient is able to breathe spontaneously. And so the patient receives the preset oxygen during the spontaneous breaths, but self-regulates the rate and volume of those breaths. So it's actually starting to take more of the work of breathing away from the ventilator and giving it back to the patient. And often this is used for weaning to see if the patient can actually breathe on their own and are they supporting themselves with enough respiratory rate and enough volume. Positive end expiratory pressure is not a ventilatory mode, but it's something that's added to ventilation. And what it does is it maintains, typically on inspiration and expiration. On inspiration, the alveoli will expand. On an expiration, they will deflate. So what this does is it provides some positive pressure at the end of expiration that it leaves the alveoli a little bit open. And what it does is it facilitates better oxygen diffusion. It helps those alveoli open up more quickly. And so that is the benefit of it. The disadvantages is that it can increase intrathroatic pressure, which decreases the venous return, which can decrease the blood pressure. So it's just a little bit of a helpful to prevent the alveoli from completely collapsing throughout the respiratory cycle. The last one is bilevel positive airway pressure, and this is BiPAP, and this is what you see the gentleman wearing here. So this is non-invasive. You can see here that this individual is not intubated. And so these are for individuals where you are trying to provide extra support for the patient, but they have a patent airway and they don't need a lot of support through ventilation. And so it's delivered through a tight-fitting mask, also a nasal mask. The patient must be able to breathe spontaneously and they need to be in a state of mind where they can cooperate. And so the indications I've seen is in acute respiratory failure with someone who has COPD or heart failure or maybe some sleep apnea. BiPAP is also used after extubation to prevent someone maybe from being reintubated. And clients with shock or altered mental status or increased airway secretions are not candidates for BiPAP because you don't want to keep taking off this mask. I want to talk a little bit about the importance of prone positioning. So this is very common with our COVID-19 patients, is putting the patient in a prone position. And so you actually reposition the patient from a supine to a lateral position, from a supine or lateral position to a prone position. It takes about 6 people to do this because you can imagine all the tubes and your intubation tube. So your endotracheal tube has got to be watched. And so the goal is to improve the lung recruitment because it allows for gravity will allow the lungs to expand when the patient is moved from a supine to a prone position. So it's used as supportive therapy in critically ill patients with acute lung injury or ARDS, or we're seeing it all the time with our COVID patients. Moving on to our alarms. So it's very important to understand what the difference is between a high pressure alarm on your ventilator versus a low pressure alarm. And one point is that you never, ever, ever turn off the alarms on a ventilator. So why do you have a high pressure alarm? Well, for one thing, the tidal volume can't be delivered at a set limit. So why is that happening? Maybe there's a lot of secretions that the tidal volume can't get through. The client could be biting the tube. So in that case, you could put an oral airway in. Maybe the patient is coughing or anxiety and you can give the patient sedatives. If there's increased secretions, you can suction the patient. The low pressure alarms typically happen when there's a leak or a break in the system. So the patient has become disconnected. There is an air leak somewhere. So in that case, you would check all the connections in the system and check the tube cuff for a leak. So let's look at some final nursing considerations. So again, very important to be constantly monitoring your patient, cardiopulmonary status every 2 to 4 hours, vital signs, breath sound, your saturation, your end tidal CO2 volumes, other hemodynamic parameters as appropriate, ins and outs, assess for complications, which could come in the form of a low blood pressure, so a decreased cardiac output. Remember what I said about the addition of PEEP, the positive end expiratory pressure, pneumothorax from that constant delivery of quite a volume and a pressure of oxygen that comes into the lungs, so it could cause a lung collapse. Atelectasis is where the alveoli stay collapsed. O2 toxicity, I'll talk about on the next page. Ulcerations and ventilatory assisted or associated pneumonia, which I will talk about on the next page, but ulcerations again from the tube moving around and maybe the cup not inflated and from aggressively suctioning. The head of the bed should be 30 degrees up and you turn your patient every 1 to 2 hours to improve lung expansion and removal of secretions. Active and passive range of motion really important because they are bed rest. Call bell in reach if the patient is awake. Establish a communication method with the patient. So obviously they cannot talk. So that's through a whiteboard, a chalkboard, maybe a list of things on a piece of paper that the patient may be asking for, having pain, need to be suctioned, anxious, and then to be giving sedatives. And sometimes we give a neuromuscular blocking agent if the patient is very anxious and restless. So O2 toxicity, I realize I've missed too many T's there. So we don't tend to typically see signs of O2 toxicity because our patients are sedated. But what would be the signs and symptoms of O2 toxicity? One thing is seizures, vision changes, ringing in the ears, mild to severe nausea, some unusual facial twitching, a change in behavior, so irritability, and dizziness, so vertigo or disorientation. Some of these, again, are hard to distinguish in a patient who's ventilated because oftentimes they are sedated. And remember to focus on the client, not the ventilator. If there's not adequate ventilation, take the client off the ventilator and maintain respirations via a bag valve mask and call for assistance. So very important to watch your patient. A little bit about ventilator-associated pneumonia. This has been a big deal in the last 10 years. And so ventilator-assisted pneumonia, or VAP, it happens when pneumonia occurs more than 48 hours after patients have been intubated and received mechanical ventilation. So we know it's related to being ventilated and intubated. And it's typically coming from bacteria from the sinus, mouth, trachea, or stomach. It's very important to implement early effective treatment And if early effective treatment is in place, it's associated with a reduced mortality. So the clinical criteria for the suspicion of VAP is a new and persistent progressive infiltrates found on chest x-ray plus 2 of the following. So an increased temperature or a low temperature, but typically an increased temperature and an increased white blood cell count, along with purulent drainage and some gas exchange degradation. So it changes in your gas exchange. Some nursing implications for VAP: maintain the head of the bed at 30 to 45 degrees when possible. Daily evaluation of readiness for extubation. You want to extubate the patient as soon as possible. Ensure endotracheal tubes with subglottic secretion drainage. These are new endotracheal tubes that are constantly removing secretion drainage. Not all hospitals are using these. Oral care and decontamination with chlorhexidine is another indication or is another way to decrease VAP. Initiation of safe enteral nutrition within 24 to 48 hours of ICU admission to boost the immune system. Hand hygiene, ensuring that you're promoting patient mobility and preventing VTE prophylaxis, so preventing the venous thromboembolism prophylaxis. So that can lead to pulmonary embolism, which can add to ventilator-associated pneumonia. So that's a lot to include in the last 40 minutes. So again, write down your questions as you go through this and bring them to our next Zoom session so I can hopefully have the answers for you.